Okay, part of it may be a little repetition, but the elbow was the crossover in between two sessions. We're going to start with an elbow case. Okay, this is a patient, 41-year-old, fall from 3 stories. I think we are seeing this kind of a little more than complicated olecranon fractures, if you want to call it proximal ulnar fractures, more often than we used to. I don't know why. But everybody sees this more complex injuries more often now. So what we do with this, so let's say this patient is, let's start on this side. Kevin, you took some trauma call too, so and you are a hand upper extremity person. You get called from the ED. If the resident calls you, let's say it's a junior resident in July, the intern in July, don't know much. What do you want them to do? Or ED physician, like they are calling you, this looks like more than a simple thing. What do you want me to do? I'm the ED physician.
I mean, I think the first thing you want to do is make sure that they're get a good exam on the patient, document their neurovascular status, and then, I mean, it doesn't look, I can't really tell if it's dislocated or not. You may want to get traction views of the arm and see what it looks like, and then maybe get a CT scan of the elbow.
Sorry, doc, nobody does traction views here.
Then we get a CT scan of the elbow.
Okay. Tony, anything to add? In ED, I'm the ED physician calling you.
I'm assuming this is closed or open? Closed?
Oh, I didn't check. Let me ask the nurse. I think there may be something bleeding around the area.
Yeah, sure. So make sure that the ED doctor or the intern also checks the skin.
Okay, we're going to assume this is closed, but some of them, as you can see on this picture, I don't remember the specific one, but there may be sometimes even like a poke hole or like half a centimeter, 3 millimeter kind of poke holes in the area because it gets really close to the skin. And on the picture, I think you can see. I can't remember for this patient, though. Let's assume closed. You want them to splint in place? Which position? Let's ask Nico. Which position you want this to be splinted, or you need close reduction?
So this is one that I'm really concerned about, potentially compartment syndrome. And it may not be at time 0 when they present, or it might not be a couple of hours later, but it could also develop like overnight. So I would probably splint this in extension in comfort and then admit them and then start my workup.
What's going on? We splint the elbows always 90 degrees. Is that correct?
I think for this one, well, I think the position of comfort for this patient will be an extension. And I don't think splinting in 90 has any benefit for this particular case.
And may potentially harm if there's a skin break, or even if there's no skin break, it may develop overnight or in the next 6 to 12 hours because more flexion is going to make that bony fragment pushing under the skin further, right? So the common default, I think, for elbow problems, we splint in 90 degrees. But this proximal ulna, olecranon type of things, I intentionally ask the residents to splint them in extension or like 30 degrees flexion at most. I think this is important for soft tissue problems. Okay. Kevin, what we do next? Okay, we get a CT. I don't know if I have a CT. I can't see the next slide neither. So we want a CT. Everybody wants CT for this?
Yeah, CT.
Yes.
Because in prior session for distal humeruses, there was opinions depending on how comfortable you are, you may or may not. Why we get the CT? To plan the surgery or to understand better what's going on? Tony?
I don't think it changes your operative indications, your approach, but I do think it helps you better understand it because I do think that this may have an element of instability, and I want a better understanding of the bony elements as well as the soft tissue alignment.
Nico, why are you getting the CT?
I get a CT to determine what my surgical approach will be. I know the olecranon is broken, and then there's no good lateral view. There's a semi-oblique. Radial head is probably broken. I'm not sure the capitellum is potentially sheared. And so it helped me confirm the fracture pattern, but then also my surgical approaches.
Anything to add on this side?
I want to see what the coronoid looks like.
Coronoid, is it that important? Right, so I call that this little bone, smaller piece of bone on the proximal ulna is probably second to the odontoid regarding the size of the bone. Very important, right? If there's a coronoid, this may change the whole understanding of what the injury is, what you must do about that coronoid. Okay, so I'm gonna go to the next slide. I can't remember. This gives a little maybe better idea of this injury. So what is this injury? Is this a terrible triad? Nico?
No, this is like a trans olecranon plus.
Okay. Something on this.
Yeah.
I mean, we hear more of these terms that I don't remember hearing these terms like 10 years ago, right? Transolecranon fracture dislocations, terrible triad, we were aware, but also this proximal ulna fracture dislocations, transolecranon basal coronoid fracture dislocations. Mayo guys came up with a classification and went with it. But as you said, there's something plus, right? All these things I said actually does not necessarily include radial head, except the terrible triad. Okay, so do you still need CT, Kevin?
I still would like to see a CT scan.
Is not enough? You don't know where the coronoid is? To be fair, I don't neither, so in this X-rays. It's hard to know exactly where this coronoid is and how big it is and how I'm gonna put that together. I think that's why it's important to get a CT. I think I put some CT. No, I did not put a CT.
Yeah, well, you sort of gave it away, but I was going to ask you what's going on with the capitellum. You could sort of see it on the previous slide that there's something off, that there's a little bit of on the right image on the attempted AP. But I think you see even more on the next slide.
So what is different other than this proximal ulna elbow fracture dislocation in this one? There's a distal humerus component too. It makes it, I think, plus even more than transolecranon. So, right, there's on the other side of the joint, or bipolar, whatever you want to call, there are more lesions on the other side of the. This makes it more complex and makes the prognosis probably much worse for the patient too. Also on the AP, what you see on this view, part of this anteromedial side of the ulna is also a kind of culprit for more instability if you don't address the anteromedial facet of the coronoid. Okay, so what we do with this one, Kevin? So how are we gonna position the patient? Let's say isolated injury. I think there's no question this is gonna do worse without surgery, short of the patient is kind of already dying that day or something. We're gonna proceed with surgery. How soon you wanna do surgery for something like this?
I mean, it really depends. I would like to do this sooner rather than later. If the patient's in the hospital, I'd like to take care of it while they're there. I don't think you have to wait for the soft tissue to calm down to do this. And if it's an open injury, you have to do it, I would do it sooner rather than later as well.
How come? For distal radiuses, you see them at 1 week, you operate at 10 days or 2 weeks. You like them instead of doing from the first day. Why this one is you want to operate sooner?
I mean, with the skin, the skin may break down if you leave the bone like that.
Right. I think, in my opinion at least, that for elbow injuries like this, if you wait 2-3 weeks, I think the outcomes and the risk of stiffness goes up, HO risk goes up. I think the sooner the better. For soft tissues, to tell the truth, waiting in this kind of injuries, displaced injuries, actually makes the soft tissues, I think, worse. Yet the swelling gets better, but the actual soft tissue are better off with the bones reduced than not. Okay, so how are we going to attack this, Nico? What is the position you're going to put in this patient on?
Position, let me think.
I didn't give you an easy one.
So I think you could actually, the one good thing is that the olecranon piece is big. So you could actually, I would probably do this supine. Let me tell you how I'd fix it, or just approach?
So let's go to positioning and approach.
I would go supine on this one.
What? Is not the door of the elbow is the back, not dorsal, olecranon piece? Why you are going supine instead of
Instead of lateral, you mean?
Yeah.
Because I think I might have to go like medial and sort of do like a posterior approach, and then I would try to fix this through, basically, it's kind of like an olecranon osteotomy, right? Like not through that exact spot, but it is an olecranon osteotomy. So I would try to fix it through the fracture. But if I'm having trouble there, I might make medial or lateral windows. And for me, you could do it when you're on lateral too, but then it's kind of working backwards. So I find it easier to do it supine, especially when the olecranon piece is big enough that I won't struggle fixing that piece.
I mean, obviously, you can fix the olecranon in supine position as a default too, but I think that part may be surgeon's choice. I think the important part, if you're going to need additional superficial or deep approaches, how are you going to get there, and your position is amenable regarding your comfort, how are you going to handle that? So that's what I think you are trying to say anyway. Tony, anything to add?
Well, I agree with that. And I think the other piece to consider is not just thinking about how you're going to access it, but what's going to give you the most trouble, right? And how that position is going to affect you. In this setting, I actually think the coronoid is going to give you a whole lot of trouble, as well as the capitellum. And I think if you're going to be in like a lateral or prone position, it's going to make that part pretty difficult to access.
Okay. Scott, sorry, I'm leaving you out, but you can comment at any point.
I would put a flap on it.
Yeah.
You see it coming? Getting infected, and we are pulling out.
We'll consult plastics for closure
Yeah.
after 8
That's
hours.
a good one. Sometimes after these cases, by the time I finish, I like somebody come in and close the wound. Okay. So where are we going to start, Kevin? Which part of this injury are we going to start? We're going to make a decision like, are we starting on the radial head? Are we starting on the distal humerus, capitellum, lateral epicondyle side? Where are we starting on this? Or are we going to build just the olecranon to proximal ulnar shaft
I think
and
I would
build
go
on?
to the coronoid first through the olecranon fracture. Fix that first, and then proceed from there. Then you can close up the olecranon, and then take a look at the rest of your.
So how you know where to put that coronoid piece when the olecranon piece is not in there? Like it's separate and displaced. Like sometimes it's so comminuted that it's hard to know where to put that coronoid. When you have the coronoid in place, like proximal ulnar and olecranon piece is reduced to the shaft, it's easier to know where to put that coronoid, right?
That isn't always the case. I've often built it off of the shaft of the ulna first, and then closed up the olecranon piece. So, I think that if you close the olecranon, if you fix the olecranon in place, and then try to reach around that and fix the coronoid, you're kind of doing it backwards. You've been getting an opportunity to look at it directly with that fracture. So I would go there first.
Yeah, different ways to do it. Again, so I think the coronoid fractures, there are coronoid fractures and there are coronoid fractures too, right? So there are different flavors, depends which part of the coronoid, how big they are, how much they contribute to the instability. And you gotta you can argue probably both ways. I usually do what you mentioned, starting deeper and working from deep to the superficial layers that have been worked out fine for me. At one point, what you're gonna do, how about the radial head? After the coronoid, what we do next? Let's say you put the coronoid back to the ulnar shaft side.
Mm-hmm. And I think if there's a radial head fracture, then you're going to address that either fix it, or if you can fix it in a reasonable way, or replace it to make it stable.
I think the difficulty in this kind of case is like how you know the height of the radial head, where to put, because you don't have the ulna length, right? So you can easily make that radial head too long regarding the lengthwise. How you decide how long that's supposed to be?
I think that's why you want to fix the coronoid first. You can see where it keys in on the ulnar side. You can see where the radial head should key in, and that would be where your height is. And that's another reason to do that first.
Would you do anything different, Nico?
So I think I know what's happening, but I don't know 100%, right? So for me, the first thing I would probably tackle is the capitellum. And since I will have basically, I feel like if I go olecranon first, I'm going to close my book. So I would see if I could get the capitellum first. I have to fix the capitellum, depending if the head is salvageable or not. If it's salvageable, then then I'll probably try to fix it. But if not, I'll probably leave it in the back table just in case I need to use it for the coronoid. And then you're talking about if you do arthroplasty, you could put in a trial and kind of wait and see. And then at some point, when you feel like you have the radial head, for me, I would say is not that important. I would probably put a trial and then see how everything kind of keys in with the ulna and the coronoid, and then sort of guesstimate maybe like the length of the radial head. So I would go capitellum, radial head, and then coronoid.
Great, great. There are different opinions. Tony, I heard that, I'm going to quote this later on for Nico too. He doesn't care about the radial head, so he wants to throw it away. Can we excise this in this scenario? This is not a terrible triad. So in terrible triads, we know we have to either fix it, replace it. But this is not a terrible triad. Can we just excise and one last thing to worry about it?
I think the decision to fix versus replace will just depend on the fracture pattern and whether or not I think it's salvageable. But I wouldn't just excise it. I think that there's a higher level of instability, and if you do that, you're asked, it's not going to help the problem, it's potentially going to make it worse.
That's a good point. I mean, we didn't look at the risk, but then, the pattern with the capitellum up, there is an axial component to this. And so, you have to think about longitudinal instability, because we're focusing on the elbow, and you may reconstruct it, and then down the line, like 6 months down the line or something, you might have instability, forearm instability that you didn't appreciate.
Yes, I mean, we have some shared patients too between Nico and I that we had delayed diagnosis of an SX-low-presti injuries, unfortunately, that we missed early on because they didn't have significant symptoms. Either they are distracted or so. I guess in 2025, the indication of the radial head excision, I cannot see really much of a radial head excision indication in acute trauma cases. Maybe in delayed cases in elderly, et cetera, but I think because you cannot know how much instability you're going to cause and how much instability is there already, I think looking for trouble to throw away just radial head excise and not to replace it. Either you're going to fix it or you're going to replace it in 2025, in my opinion. Do you guys agree? Right, so I don't remember I did excise a radial head acutely at all. We're not talking about chronic radial head non-union, malunion, that kind of stuff in elderly or symptomatic stuff later on. Yeah, okay. So I will show what I did. I think this is a little further. I think I started with the capitellum too, distal humerus side too, because I didn't know, I wanted to know where to put these joints and the radial head. I think I started with the radial head. The way I go with this, I don't have all the slides, but I try to work through the olecranon fracture side. There's two ways to go. Either you're gonna put the olecranon piece on and build everything around it and make a different skin incision and approach, or deeper approach, the same approach but deeper through the same skin flap, and get to the radial head and do it. I go back and forth. I provisionally reduce the olecranon piece after putting the trial radial head, get an X-ray. If I like it, as you can see, the trial on the radial head, I check the stability, I check the height, length, and everything. If I like the radial head, then I put the final radial head back in there after taking down my provisional mini plate on the olecranon and put back on. So that's not the order I went, but you can do either way. I think there's no wrong way. As far as you address all the bony injuries, and then at the end of the case, you got to check if there's any ligamentous instability. I think one of the keys about this elbow fracture dislocation group, which one is, doesn't matter. After you think you fixed everything you can, check again to check the soft tissue stability. If there's any other ligamentous instability at all, even if there are some subtle things, it's better to address now because they will come back and haunt you. I think this one went relatively well. I think, I don't know if I have longer time follow-up, but this one was looks pretty good compared to where we started. Again, a lot of mini plates around the area, even at the area, as you can see, on both sides of the proximal ulna, closer to the sigmoid notch, which is obviously overlapping with the radial head replacement.
Utku, did you have any concerns about a synostosis? And is there anything to do in this acute period?
I have a concern with synostosis because I see them. More severe the injury is, more severe around the PRUJ area. I try to start range of motion as quick as I can. Sometimes selectively, I may give indomethacin. Again, this is my opinion. This is not literature supported or anything like that in acute trauma with fracture, non-union risk, etc. I don't think there's much you can do. I don't do anything prophylactically other than maybe giving anti-inflammatories early on. I don't know if you can prevent short of moving the, again, it's a good point actually. When you do elbow surgery and you give a PT order, a lot of times we say elbow range of motion this and weight bearing is this. We don't mention much about the forearm, but forearm is connected. In my opinion, you should mention about the forearm prostration for the PT orders. Otherwise, they may not do it. Even point to the patient too, that they start the prostration. That's probably the best thing you can do to minimize the risk or prevent the synostosis, in my opinion. Anything else you can think of, Kevin, Nico?
I think early motion, and then if you want, I guess you could do, what is the NSAID that people don't tolerate well? Indomethacin.
Yeah, or Celebrex. Some people will use Celebrex, COX-2, instead of indomethacin. Indomethacin sometimes causes some weird symptoms too. I hear like dizziness, for example.
Yeah. I have a question about this case. I still haven't ran into this problem, but I worry about it, is if you put all this metal and then one thing I try to do, I'm try to be as soft tissue friendly to the little pieces I'm reconstructing because the ligaments might be attached to it. So I just peel off whatever I need to reconstruct. But then I know one day I'm gonna run into a situation where my elbow is unstable and I have too much metal or I don't have any real estate. I know how to reconstruct like a LUCL, for example. But then what if I have fracture with metal and I can't reconstruct the LUCL? Like, how would you approach that?
So great question. Actually, I will step one step back. So one of the reasons to get the CT scan and review that CT scan, I think you should look where the insertion of the LUCL and MCL are. If there are fragments that are in the attachment in that area, and you got to be careful what are kind of peeling off the soft tissues in that areas. You should use that kind of reattaching the pieces as soft tissue friendly as possible. I encountered cases, obviously, what you mentioned too. You do all these things and you check it. You feel like there's an LUCL detached or mid-substance tear that you cannot really, putting an anchor on the distal humerus is not going to work. You need to reattach somehow distally, the repair or reconstruction. I think reconstruction is much harder, but you can put an anchor in the area, small all suture anchors that I usually start with. I think you can do that. That's usually my bailout. Reconstruction acutely, I don't like the idea of reconstruction acutely anyway. I think repairs usually, if you can do it well, or internal brace, usually works fine in acute cases. I usually leave the reconstruction for later on. But it's a good question. So if you put all these mini frag plates or everything in there, fixation for bony injury, then the insertion of the LUCL or MCL, you have like, is already a mini plate on there where I was going to put an anchor or anything like that. This may be a problem. I think that's why when you review the CT scan, 3D recons, you should look up all these small fragments that may have the attachment of the MCL and LUCL that doesn't show up on X-rays, obviously. Okay.
I'm not sure how popular this idea would be. One thing I wouldn't want to leave an elbow unstable. I would probably, and let them move, because I think my fixation is gonna fail if I have instability. I would probably just cast them, honestly, for like 6 weeks, and then get them stiff, and then come back, because I could do contracture releases, right? I would probably come back and then deal with ligamentous reconstruction when some of the bone is at least healed. So I don't have to worry about failure fixation of the bone. I don't know what you guys think. Is that
What about
crazy?
a static X fix?
I try not to X-fix at all, if possible, because I think I just don't like the complications with like pin sites. But I think that's a very reasonable thing to do, but I probably wouldn't, I'd probably cast.
I think the common scenario would be this. You do whatever you can during the surgery. At the end of the surgery, you are looking in an elbow. Either you can't figure out why there's still some subluxation in certain positions, or there's some instability and you don't know how to appropriately repair or reconstruct. You're not making that elbow more stable, basically. You ran out of your options during the case. What to do at that point? This is a common scenario with the terrible triads or other elbow fracture dislocations. I think you have two options at that point. I personally like the idea of X-fix in that case. I try to not to get there, obviously, but if that's the case, you can do the options in the literature are, you can do a casting. Again, the worst thing that can happen in unstable, stiff elbow, like combination of unstable and stiff elbow, is basically instability and the stiffness goes together. It's better to have a located elbow. The goal is to have a located elbow. That's what Dr. Lee is trying to underline. Then subluxed elbow with 6 weeks or whatever. So the other option would be static X-fixes because it's easier to do. There was a kind of an era that I used to, that I still sometimes use a dynamic X-fix, but you're going to make sure that that X-fix stays concentric with the center of rotation of the elbow, which is not easy to do throughout the range of motion. You can put these patients in a static X-fix, keep them 2 weeks or 4 weeks, then take them off. This has been pretty well reported and seems to be helping to the scar tissue forming in a located elbow, helping with the stability. I think you can do either way, probably. I like the X-fix idea better because I don't know, somehow 6 weeks of casting seems to be a little too much. You can't do forearm motion, anything like that too. But this is an option. Again, the priority to keep the joint located. Also, there's some cases, elbow instability cases, you can use this internal X-fix that we did not talk much about it, IJS. I think this is kind of coming up more and more in use for sure in everybody's hands. So you can use that too there are some tricky parts about that too, because you got to still put that pin, central pin at the center of rotation. If you're going to have a real estate, for example, in this case, you won't have that because the lateral side is broken already. You can put on the medial side, but also it's a different, like there's too much hardware. I don't think in this case it will work, but a lot of cases you may make that work, especially in terrible triad cases that distal humerus is not involved.
Should we do that for him now?
Yeah.
Can we get Dr. Ding's case, please? Thank you.